nutrition, and different other neurocognitive health intervention is so important that so we're going to go through each of those. In the end, we'll have a Q&A so we can have a discussion or any questions you might have. So save your question for the end of the session so we can finish up and then we can have an open discussion. All right, so with that, I have no disclosure to make, financial or any. I have nothing to disclose. And let me see if I'm going to be talking about three different topics. So the nutrition and then the mindfulness and yoga program, which I'm going to cover a little bit on my own. And then, of course, from neurology perspective, I'm going to talk about neurocognitive, advance in neurocognitive disorder in Alzheimer's disease. So this is coming from my educational background. So I'm disclosing that because of my other curricular activities, especially in the nutrition and yoga and mindfulness. I'll be sharing some of my outside hat other than a neurologist or a neuropsychiatrist. So I'm going to talk a little bit about my experience in yoga and mindfulness and exercise for brain health, and also nutrition and some of the specified diet that is good for Alzheimer's disease. Okay. So before we start, this is a really busy slide, but I'm going to walk you through. So this is the slide about how the normal aging, getting older, transition into cognitive disorder. So this is really important to understand so that we can understand people's problem way before their symptoms start some days, So our dream is how can we identify and diagnose patient way before they started having dementia symptom, because we know that there are chemicals, the two proteins that is causing the disease called Alzheimer's disease. One of these protein is called amyloid and the other one is called tau protein. This amyloid and tau, these are the two proteins that is actually present in every human being. So even in normal, without that, we don't have a human brain. But we have a way to actually make that healthy and keep that healthy before it get toxic level or toxic state. So I'm going to share a little bit of biochemical pathways of amyloid, how the amyloid goes into this toxic amyloid that we talked about that cause the disease. So we have this nerve membrane. That nerve membrane has this protein called APP, which is called amyloid precursor protein. In normal life, normal non-dementia cases, normal healthy aging, we all have that amyloid precursor protein. It's break down by two enzyme actually. One is called gamma secretase and one is called beta secretase. These two enzymes break that protein, make that into what they call monomeric amyloid. This mono means single, meric meaning it's a single chain amyloid. That is actually soluble in the water. So our human cerebrospinal fluid, which is our brain fluid, can eliminate that before anything become toxic or anything through our blood-brain barrier. And that is normal and healthy. That doesn't cause Alzheimer's disease. However, this enzyme also can make some genetic transformation for some reason. We don't know exactly why. This amyloid can go through some genetic transformation in the molecular structure. And to make it simple, without going into further details, it makes some biotransformation in the molecule by adding some metals like copper and zinc, and some of those metals make it what they call oligomeric amyloid. So it's no longer monomeric amyloid. Mono means single chain. Here we have oligo. Oligo means multiple chains. So these multiple chains mixed up with this metallic like copper and zinc those make this amyloid peptide unsoluble, and they kind of collect together. So this becomes aggregate, and this aggregation keep going on to an extent that it makes what they call amyloid plaques. This amyloid plaque, like a cancer cell, amyloid plaques is like a cancer cell. Ultimately, what they do, they replace the normal human brain, normal tissue, that normal healthy neurons, normal healthy nerve cells, and the entire, like a cancer cell, like the way a cancer cell does. And then the entire brain becomes amyloid plaques. Once amyloid plaques build, that's the beginning of the disease called Alzheimer's disease. But this amyloid does not cause the progression of the disease. So it starts the disease, but it doesn't make it progress. It doesn't make it decline. What it make it decline and what it make it progress is by another second protein, which is called tau protein. This tau, which is the spell as TAU, that tau protein is also healthy for our brain normally. But if there is a genetic reason, we don't know why, but for genetic reason, this tau protein also go into some kind of biochemical changes in the molecule. So it becomes what they call hyperphosphorylated tau protein, meaning they have a lot of phosphorus, like a metallic things, phosphorus accumulation around the molecule. And those hyperphosphorylated tau protein also glued together make it what they call tau tangle. So we already have the amyloid plaques, and now we have the tau tangles. This amyloid plaques and the tau tangle together is the marriage, together cause the disease called Alzheimer's disease. So this tau protein is the reason the disease start to progress. Every year, every month, every year, it declines. So this declination, this progression is due to this tau accumulation, whereas the amyloid is the cause. So in the end, this disease is caused by both of these proteins. But what we know now with all our technology, that this protein accumulation starts at least decade, often up to 20 years before people actually have clinical symptoms. Meaning, you can have a dementia symptom in your 60s, but this protein might be already there in the brain at least 20 years before that. So meaning, what we say Alzheimer's is the old people's age disease, it may not be right. Alzheimer's may be a young people's disease, meaning it starts when you are in your 20s, 30s, and 40s, but you may not have the clinical symptom development to cause full-blown dementia until you are in 50s and 60s. So what can we do if we could have a way to diagnose way, way early, like the way we do by mammogram for breast cancer, like the way we do by colonoscopy for colonic cancer, like the way we do a lot of other disease like cholesterol, like all kind of wellness visit that we do for the primary care physician's office. So the future, my real dream is we have this scan called amyloid PET scan, which is a PET scan that can actually show if you have amyloid in your brain or not. This kind of PET scan someday, when you go to a wellness visit for a regular checkup by your primary care physician, if you have a family history of Alzheimer's disease, we may be able to do the scan for you, and hopefully by then we'll have a cure for Alzheimer's disease. So if the scan is positive, then you may not have to wait until you're another 20 years until you become 50s or 60s. You may start on treatment, then the Alzheimer's disease will never happen. Alzheimer's disease will be a history. So this would be our future goal. So we are trying very hard to create a lot of medication on those enzymes. Remember the enzymes I talked about that cascade, those amyloid accumulation and the tau accumulation. We are creating a lot of different biochemical way of pharmaceutical that could that could block those enzymes so that your amyloid production can be decreased, or we could have a amyloid elimination, meaning how can you get rid of the amyloid as much as possible from the brain. So those are the two big way of different pharmaceutical companies now working on creating drugs for Alzheimer's disease. So by coming back to our first slide, so think about what I just said, that your brain pathology comes way before your symptom development. So first thing that in this slide you see is called asymptomatic stage, meaning you have a normal aging and you have no clinical findings and you have no brain pathology, meaning there is no amyloid tau protein in your brain yet, those toxic amyloid. So that is the asymptomatic healthy aging stage. Then at some point, this amyloid accumulation and tau accumulation start, but you still don't have any symptoms. You still have no memory problem. You're driving, you are becoming working full time. You have no trouble paying bills or any kind of cognitive issue. And that is what you call asymptomatic or pathological Alzheimer's disease. Meaning, only way at that stage we can diagnose you for Alzheimer's disease, because you have no symptoms, is by doing a biopsy. Biopsy cannot be done for brain until you're dead. And because that's only can be done on autopsy. So that's not going to help. But fortunately, we now have a brain scan that I was talking about called amyloid PET scan. This amazing amyloid PET scan can actually diagnose, actually see if you have amyloid in the brain while you're still alive. So if we have unfortunately, it's still not covered by Medicare yet. It's only used for research. So it has been used in clinical trials and research, but I was involved in a big studies at Hopkins called IDEA study. You probably heard about it. IDEAS is a big, IDEAS. It stands for Imaging Dementia for Amyloid PET scan. We had 18,000 participants throughout the United States in that study, and they detected that this is the amyloid PET scan was so specific and very close specificity and sensitivity to diagnose a reliably Alzheimer's disease without biopsy. So it's pretty much clearly and it helped you to diagnose a lot of the undiagnosed or poorly diagnosed or misdiagnosed patient who otherwise was not diagnosed as Alzheimer's disease or was falsely diagnosed as Alzheimer's, but then found out you don't have an amyloid plaques in your brain. So your diagnosis was revised. So this scan revolutionized this. It's still not approved by Medicare for commercial purpose, but it is available in most radiology center in the country, especially academic center, where it takes a fortune. It at least $8,000 to $9,000 for the scan. So it's still not a reliable option for commercial purpose. But this pathological diagnosis that I have used, number 2, can be diagnosed at that stage. So again, the summary of this pre-symptomatic Alzheimer's disease is you have no symptom, but your brain already has the pathology. So you have a positive brain pathology of amyloid and tau. And if you do a amyloid PET scan or the tau scan, it would be positive. And also if you do a cerebrospinal fluid with a lumbar puncture, then you can actually see amyloid beta, this chain A beta 42 and tau in the cerebrospinal fluid. That way the lumbar puncture, but not symptomatic. Then it goes on and on for maybe several years again. At some point, again, depending on person to person, it varies. But as I said, it may be decade after 20 years after the accumulation of amyloid and tau started, people start to have some symptom. Initially, the symptoms are only subjective, not objective. meaning they only feel like, oh, I can't remember things or I can't do like the way I used to do before. Who doesn't have that problem? As we get older, everybody feels that way, yeah? So that doesn't help because we all say, you're just stressed out, that's normal, don't worry about it. But it's not like that. It's actually a little bit more than that. They actually do believe that they are not doing the way they used to do. But if you talk to their family members, they say, no, he's fine, or she's fine. We don't see any problem yet. So objectively, people don't see it. It's only subjective complaint. And also, if you do the scan, only scan that would be positive in this stage would be the amyloid PET scan, not the other PET scan that we do, FTG, because FTG PET scan pick up the functional brain when the brain function start to deteriorate, like a glucose metabolism scan, that is a sugar scan we talk about. So that way we can see how the metabolic state in the brain changes with the development of the disease. So basically we start at the molecular level to the cellular level, and then comes into the neuronal level. So when you become functional scan after a few years, it comes in the structural scan imaging like a MRI. So MRI and CT scan may not be positive in the early stage. PET scan even may not be positive too early stage. So the amyloid scan would be the earlier diagnosis. Then maybe we can also screen pretty much very sensitively with the FTG PET scan, which is pretty good for diagnosing different types of dementia, which is, by the way, reimbursable by Medicare and other insurance, as well as a specialized MRI with what we call volumetric MRI, where you can actually look at the MRI, see the volume changes. I have some scan I was going to show you in this presentation to see how we can diagnose that. Okay, so that's the subjective cognitive decline. Then it goes on for years, and then you start to have some objective feelings, meaning now your family members can also see the problem. So now you have a subjective complaint of memory, and then you have an objective validation that, yes, I do see my mom or dad has some problem, but they will say it's not that bad. They're still okay to drive. They're still okay to do everything. So it's not changing their activities of daily living skills. And that is what we call MCI, mild cognitive impairment, which is also called prodromal Alzheimer's disease, prodromal or pre-dementia more likely. And that we see that a lot of people are lucky. They 30% or so can stay at the MCI, doesn't go into Alzheimer's, or maybe they die before they go to Alzheimer's. Whatever, they don't convert in minority cases, but some majority cases it does convert to full-blown Alzheimer's disease and dementia. Then it becomes dementia mild, then dementia moderate, then dementia severe. So these are the chronological staging of the disease development, with a healthy aging to pre-symptomatic pathological Alzheimer's disease, to subjective cognitive decline, then to MCI, then to mild dementia, then to moderate dementia, then to severe dementia. So you got the point. And then we also wanted to see what is dementia. This is the most common question I ever get. Is my mom has dementia or my mom has Alzheimer's disease? It's a very common question I get. Is Alzheimer's dementia or dementia? So people get confused that, well, my mom has dementia, but I don't think she has Alzheimer's, So, so that's very confusing. So dementia is actually not a disease, it's a syndrome. So it's not a diagnosis of the disease, it's a syndrome, meaning collection of symptoms and signs. So loss of memory is one, we call it amnesia, that is a symptom. Loss of executive functioning, like the functioning that we need from day-to-day functioning, like problem solving, organizing a day, making a decision for yourself and for your finances, maybe making a problem solving, making multitasking ability, like taking a shower, taking a cooking skills, making a cooking or dinner. These are multitasking, multiple level of instruction needed. These are all sequential motor tasks that is executed by the frontal lobe, which controls our executive functioning. So that's the second cognitive domains or symptom development. Then we have something called motor planning or executing things that we do every day, things that we learned as a child, how to tie our shoes, how to put a belt in the, how to put a makeup, for example, how to comb hair, how to swallow fluid, how to chew food. All kind of simple things that we learned as a child is called praxis. Praxis is the motor learning. When you lose that, it's called apraxia. Apraxia is not a paralysis, meaning you don't have any paralysis or weakness, but you don't know how to eat with a knife and a fork anymore. You don't know how to tie your shirt anymore, or how to button your shirt or tie your shoes anymore. So it's called apraxia. So apraxia is another symptom of dementia. So we have the amnesia, memory problem. We have the apraxia, this motor functioning problem. We have the executive functioning problem. And then we started to have what they call agnosia, or loss of recognition. So they have difficulty recognizing objects. So if you show them a pen, they don't know what it is. If you show them a watch, they don't know what it is. If you show in a familiar face, like in severe cases, they lose the familiarity of their own children or own family members. They can recognize their face. They will say, "Oh, you're not my daughter," or "Where is my daughter?" So they can recognize their own children, and those are the symptoms. We call it agnosia. So now we have those 5 A's that I talked about. So the amnesia, which is the loss of memory, apraxia, which is the doing the daily task like buttoning shirt, combing hair, doing everything like the way we learned as a child. Agnosia, loss of recognition, absence of executive functioning, like doing a sequential task like shower, cooking, driving, things like that. And then finally comes also a language deficit, where you lose the language fluency or comprehension. So your language become either slow and not able to reciprocate, because what they call aphasia, or you can have aphasia of comprehension, meaning you are fluent but you don't know what the other people are telling you. So you have difficulty comprehending other people's word. So these are the 4 or 5 A's. You don't have to have all of them to call dementia, but you do need at least 2 or more to count it to be the criteria met for the cognitive domain to diagnose dementia. So the dementia diagnosis has to be done by looking at the prodromal, or this how the disease started, whether it changed your lifestyle, whether you dropped from the pre-morbid level of functioning, like the way you function, there is a drop from that level of functioning, and then you have to have at least 2 or more of these A's, whether it's a memory or executive function or apraxia or agnosia or aphasia, and of course your scan would be positive for the brain pathology at that point. So these are the basic understanding of the diagnosis of dementia and how the aging, normal healthy aging, becomes dementia. So this is the slide that I wanted to show you, the amyloid and tau looks like. So this is the pathological slide of the amyloid and tau. And this is the stain that produced this kind of stain is called A beta plaques that looks like that. And this, like a worm-like, the snake-like thing, is the tangles of the tau. So this is the cause of the disease. This is the progression of the disease that you can see when you do a biopsy. And this is the scan that you see with the amyloid PET scan. So when you do the PET scan, you see that lack of these areas of the parietal and temporal lobe, which is the areas of the brain called spatial brain and the memory part of the brain get this amyloid plaque accumulation. So that's how we diagnose very clearly about the Alzheimer's disease. This is another PET scan called FDG PET scan. So this is the sugar PET scan where you can inject a radioactive sugar and it goes through your brain, through the blood to the brain, like the way we can track a shark in the ocean. Yeah, you put a shark tag a shark, and then you can see where the shark is going. This is how the similar. They give you an injection of a radioactive sugar, and after half an hour, they put you in a scanner. And if you have a healthy brain, the sugar, our brain needs sugar, so sugar should go everywhere in the brain. But if the sugar doesn't go certain part of the brain, we think that part is not utilizing the sugar, meaning that part isn't working. So if the sugar doesn't go in the frontal, especially in the frontal lobe, certain areas, and the anterior part, front part of the temporal lobe, we call it frontotemporal dementia, with a different type of dementia than Alzheimer's disease. Whereas if it goes to the memory part of the brain and the spatial part of the brain called temporal lobe and parietal lobe, we usually call that as an Alzheimer's disease. So that's how we diagnose very nicely Alzheimer's disease, frontotemporal disease, and also we diagnosed with the Lewy body disease where the sugar doesn't go in the back of the brain. So that's kind of what the Lewy body dementia looks like in the FDG PET scan. And this is how the MRI, the volumetric MRI looks like. So when you do the volumetric study and the structural MRI study, you see the hippocampal area get atrophy. So hippocampus is the area for our condensation of the memory. So this is the memory area where we have this memory formation when, with a chemical called glutamatergic pathway. That glutamate, which is our excitatory neurotransmitter, help us to condensation process with the memory. It only happened when you're sleeping at night. So everything like I am talking to you, you're gonna forget like this if you didn't sleep tonight. Only it will be condensed to memory if you do have good night's sleep. Then this glutamate comes to hippocampus and makes this condensation of the memory. So the sleep is so important. That's why when you're not sleeping good, you may look like you are demented. So that's why sleep disorder can look like pseudo dementia. It looks like dementia. So every time I see a patient with dementia, I always look for sleep disorder to rule out. Because if somebody has a sleep apnea untreated, or any kind of sleep disorder untreated, or from depression, they have like a sleep disorder due to depression, that can look like or mimic symptoms of dementia. But these symptoms are so easy to fix. So it is called reversible dementia rather than Alzheimer's disease or degenerative brain disease. So this is a slide about the risk factor for dementia. What are the risk factors? So we have several risk factors that we cannot modify, and we also have several risk factors that we can modify. So first of all, things that we have no control over is age. We know Alzheimer's get more prevalent as we get older because amyloid and plaque accumulation increase with aging. Yeah, we cannot change our age. We cannot be a young person. Yeah, we cannot change. So this is a non-modifiable risk factor. It is what it is. I'm old. I'm old. You can't go back. Second is the sex. We have in evidence incidents that more, although man is getting more now, but still is female higher rate than the men for Alzheimer's. There's a lot of different ways of interpreting that because man has a lot of vascular disease, so their death from cardiovascular disease is very common, and that happened earlier, almost like before you get Alzheimer's, they die. Or maybe the other hypothesis, people say women live longer, so they have higher risk of development of Alzheimer's disease than men. But whatever it is, it's not modifiable, so that's nothing we can change. Number 3 is the race, certain race. But what is modifiable is those are the things. Number 1 are the things that bad for your heart and bad for your brain, for a stroke or a heart disease. So like obesity, sedentary lifestyle, or lack of exercise, or smoking definitely, and drug abuse. Diabetes is a big one, and high blood pressure, high cholesterol, any history of stroke or head injury or trauma or falling. So, more you fall, we now know more you develop the tau protein that I was talking. Remember the tau protein I talked about? That is causing the progression, the decline of the dementia because of the tau. More you fall, more you get head bang by concussion or whatever, you get more and more tau protein. That's how we see a lot of the football players now getting young kids now getting dementia from concussion, and we call it it's a different type of traumatic brain injury related dementia that Muhammad Ali initially started to notice in his early age when he was boxing. They used to be calling a different term called dementia pugilistica, which is the mean of boxer's dementia. They used to call it. But now we call it CTE, chronic traumatic encephalopathy, which is basically a term we use for multiple concussion. It's most common in football players or any contact sports like soccer players or rugby, any kind of contact sports. But it can also happen with older, our normal healthy older individual if we more falling, or young child if they are falling a lot. So multiple falls can develop the similar kind of pathology. So that is what another risk factor, that how do you prevent falling and this kind of head injury. As we talked about, poor sleep hygiene and sleep disorder is a risk factor for dementia. Mood disorder, depression, stress is a big risk factor. So more you are stressed out, more you are anxious, not relate, as you know, stress induces the vascular cascade in the heart, in the brain, increasing chance for heart disease and stroke. Similarly, it increased chance of Alzheimer's disease. So stress management is so important. Anxiety, depression, treatment of those is so important. Treatment of sleep is so important. And then finally, sensory deprivation, meaning we have to correct our sensory deficit, hearing deficit, visual deficit. So I cannot do a evaluation for cognition until I make sure they can hear me and they can see me. So because hearing impairment, if you're not hearing really good, how can you memorize then? Because you may not remember because you're not hearing correctly. So those needs to be corrected as much as possible. All right, let's see the next slide. So the integrated pathway for the treatment planning for dementia care has to be, of course, the medication is important, this cognitive enhancement therapy. We have two kinds of medication. One is called choline esterase inhibitor, which increase a chemical called acetylcholine, which is also, a chemical for memory. That is the one that we see with this medicine. They increased it, like donepezil, which is called Aricept, rivastigmine, galantamine. These increase the acetylcholine. Whereas the another one called glutamate agent or NMDA receptor antagonist, which has a name for memantine, which is a class of drug that increase that glutamate in the brain. What we found out, when you combine these two together, it slows down the disease progression significantly. It doesn't do alone. You have to do the other stuff together. So you have to make sure you are not stressed out, make sure you're sleeping, make sure you're not depressed, make sure your anxiety and other psychiatric comorbidities are well stabilized. And then also make sure you have a cognitive health strategy, and that would be our talk. So we're going to talk later about that. Okay, so the strategy would be a good wellness visit. So the primary care can make sure your blood pressure, your cholesterol, your weight, everything is normal. So check your cardiology. Your primary care is a must to make sure you have a regular visit, regular blood work. Healthy brain food, mind diet, we're going to talk about it a little bit later. Physical exercise, mental exercise, and cognitive exercise. Physical exercise, even daily walking, is a good start. there is something called chair yoga. Chair yoga is very, very common in a lot of the assisted livings and as day program implemented yoga. Yoga is one of the, as I know, I think you heard, I am a yoga teacher. I actually trained as a yoga teacher because I brought yoga in the mainstream neurology to because I see a lot of potential for yoga as a physical therapy, how yoga can be utilized like a physical therapy to maximize your cognitive function and physical function. So yoga has been used for Parkinson's disease, Huntington's disease, MS, depression, anxiety, panic disorder. Is a lot of medical use in terms of yoga therapy. Reading is a great exercise, and of course, the cognitive exercise like crossword puzzles, Sudoku, brain game, these are all good for brain exercise. So, yes, so and also, certain medication you always have to avoid, like certain medicine that can cause dementia or dementia like confusion, which are called antihistamine, like a over-the-counter cold medicine or sleep medicine that most pharmacies sell, like Benadryl or Benadryl-like substance. And those are called antihistamine. So just remember the term antihistamine. Histamine is a chemical in the brain which keeps us alert and awake. So antihistamine will make you opposite. So that is why it can make you sedated, make you drowsy, makes you sleepy, makes you confused. So it is a no for anybody over 65, or even if you have any form of cognitive issue, do not ever let anybody prescribe you antihistamine, because that can kill you. That can make your dementia go further, faster rate. Okay? There is a lot of alternate for sleep, which is more healthy and safer, but not those over the counter. So before you pick up a over the counter medication, please consult your physician and tell them that you're taking it. And similarly, benzodiazepine, which is overly used in United States for anxiety, like Xanax, Klonopin, Ativan, and especially in geriatric patient, older age, and definitely somebody with already has dementia, because one of the two main side effects of this medicine is ataxia and amnesia, meaning loss of memory and loss of gait disturbance. So when you already have unsteadiness in gait and memory problem, why would you prescribe this medicine to somebody who already has trouble with memory? So this is a very serious issue that you should talk to your physician if you are on those meds. Similarly, anticholinergic is another class of drug. So acetylcholine, remember the medication donepezil I talked about, Aricept, those are called acetylcholine medication. Anti-acetylcholine means these are the medicine would be opposite to Aricept. So these would be opposite. That means it will actually make you demented, not help you to dementia. And these are the side effects that you have in a lot of medication, including one of the most common urinary bladder medicine that a lot of urologists normally will prescribe, called ditropan. This ditropan-like medication can really make you confused. Or in Parkinson's disease, we prescribe something called cogentin or benzotropine. So these are not a good idea for somebody who has dementia or older age. So these are the things that you have to be careful, and that's why you'll be better off seeing a geriatric specialist as a primary care physician rather than, at least get an opinion, because most geriatricians are very much well educated about these effects in older age, so that they can pinpoint which medication is not good for you. And then definitely quit smoking, limit alcohol, and then sleep hygiene. So with that, I'm going to just fast forward a little bit because of the time. I'm going to go fast forward a little bit. So let's bring you to the nutritional part. So our nerves are all about neural pathway and all the chemicals. See these types of neurotransmitters we have. We have amino acid. Amino acids are the building block of protein. You know how we eat protein? These are the building blocks. So if amino acid, protein is like the building of, it's like a big building. What makes the building? By multiple bricks, yeah? All the bricks you stand together, make a wall, all the walls make a building. So all the little bricks are the amino acids, and then each of the walls are what they call peptide. Peptide is like a wall. Multiple walls make a building, yeah? and multiple peptides together make what they call polypeptide. Poly means many. This polypeptide chain ultimately makes the protein molecule that meat, we eat meat and fish and eggs, these are all protein. So see, everything that you eat and everything that we have in our brain and in our body is basically almost similar. So what you put in your mouth, before you put in your mouth, think about it, what you're putting in your mouth, because that may count someday. So be careful with those. So that's why this type of neurotransmitter, as you can see, that histamine, serotonin, norepinephrine, dopamine, melatonin, these are all neurotransmitters in the brain. So they brain like this. So the nerve cell end and then release these chemicals. They goes to the next chemical. This is how nerve pathway. It's like a train. You know how a train works. So if you have to go to Pennsylvania from Long Island, there is no direct train to go to Pennsylvania. So you take a Long Island Expressway, a Long Island Rail to go to Penn Station, and then you get a train, Amtrak, from Penn Station to Pennsylvania. So the Penn Station is the junction. We call it in the brain, Penn Station would be junctional neuron, whereas the Long Island Expressway, Long Island train, this is like a pre-symptomatic or presynaptic neuron, like the way I'm showing. And then the other one is the postsynaptic. So the one neuron ends, then the other neuron goes. So the Penn Station, you get a lot of different train, Boston train, DC train, Pennsylvania train. So we have similar in junctional neuron, we have a lot of different nerve pathway going a lot of different direction. That's how brain talk to each other. So these are the monoamine like dopamine, serotonin. Most of them are, the dopamine comes from something called phenylephrine and tyrosine. Tyrosine and phenylephrine is actually there in our food. As you can see, lots of the food has it. So all the things that omega-3 fatty acid rich fish like salmon has those, all the nuts has that, all the great plant-based protein like avocado has that, almond, all the brain rich nuts has those, dairy products, some dark chocolates has it, and also there are some animal product like chicken and turkey and beef has some of those. So that these are the sources of a lot of those protein that we see, and amino acid that we see with the neurotransmitter. So this is the dopamine slide. Dopamine is one of the happy chemical, one of the chemical that keep you alert and awake, and it keep you motivated, keep your energy. And this is the pleasuring, anything that pleasurable, like love. Love is a pleasurable thing. So every time you fall in love, your brain release dopamine because make you happy. So anything that make you happy is because of the dopamine. So this dopamine is basically is a chemical that improve your mood, improve your motivation, improve your happiness. And now we know this dopamine also work in the reward pathway in the brain. Reward pathway means this is the pathway in the brain which goes from the nucleus accumbens, one of the areas of the brain, to the frontal cortex. That is this pathway is the reward pathway, meaning the thing that makes us happy and want us to do more and more about that is called reward. So this rewarding behavior, like addiction, is dysfunction of that pathway, because you feel like, oh, that tastes so good, maybe I'll get a little bit more, and then maybe I'll get a little more, and then I'll get a little bit more. Next thing you know, you are addicted to it. So this is the addiction pathway. This is the substance abuse pathway. Not just substance, it can be addictive behavior for anything. From gambling, you can even have Parkinson's patients, some of the Parkinson's medication or subthalamic, the DBS, therapy for Parkinson, they improve so much dopamine. Now that you don't have Parkinson's disease like a motor symptom, but a lot of my patients end up in gambling because we now created a gambler, like a pathological gambling or an addictive behavior. I have a patient whose Parkinson's symptom is improved with DBS. Now he's very impulsive. His impulse control is worse because those are also the dopamine. So it's very interconnected how the dopamine works in the brain. This is the funny thing. I say, will you be my dopamine? So this was a little bit of history. Like we fall in love. This is a very oversimplified fashion. I'm going to explain. So we fall in love, and we say on the Valentine's Day, will you be my Valentine? So we were joking when I was in my residency that instead of saying, will you be my Valentine, maybe you should say, will you be my dopamine? Because dopamine is the reason you fall in love. Dopamine is the reason you feel attracted to each other. All right. So instead of saying, you will be my Valentine, maybe it's all about dopamine, the way that you release your formation. So this dopamine is the molecule of love, molecule of pleasure. It's also the molecule of pain. So all the pain pathway in the brain, all the pathways of addiction, addictive behavior is in the brain. It is also the pathway for movement. So lack of dopamine is the cause of Parkinson's disease, whereas too much dopamine causes schizophrenia, like psychotic disease, like hallucination and delusion. So this is very complicated. So the depletion of dopamine look at that, Parkinson's, depression, ADD, whereas the higher dopamine makes you psychotic. So this is the opposite of each other. So this is why you have to be careful with medication release for Parkinson's. For example, if you are on too high dose of Parkinson's, your dopamine may be too high and you may start having hallucinating. Or if you have too much of the antipsychotic medication for schizophrenia or bipolar disorder, then dopamine may go so low that you may look like Parkinson's. So this is what happened between these two diseases, schizophrenia, Parkinson's disease. This medication can look one or the other. And this is the acetylcholine, the memory molecule that I was talking about, that Aricept work, the donepezil work on that. So these are the food that has a higher acetylcholine or choline. So acetylcholine comes from this B reaction. And it's complicated, but I will walk you through. Biochemistry was my favorite subject. So I love the biochemistry, but I will walk you through. So we have something, an amino acid called homocysteine. Normally, homocysteine convert into methionine. This conversion these are the cofactor. They need a vitamin B6, vitamin B12, and a folic acid in terms of converting homocysteine to methionine. Why is important? Because homocysteine is not good for you. A high homocysteine makes your blood thicker and glued to each other, meaning it can induce stroke and myocardial infarction. So our homocysteine converted to methionine, and methionine converted to what they call SAMe. SAMe, you can actually see a lot of the healthcare store, they have food that rich in SAMe, which is a big name for S-adenosyl methionine. And SAMe goes to choline, and choline ultimately give rise to acetylcholine. So see the acetylcholine, which is our ultimate memory molecule, these are the reaction. Can you imagine if you don't have a vitamin B6, if you don't have a vitamin B12, if you don't have a folic acid, this conversion doesn't happen this way. So you have a high homocysteine level and low acetylcholine level. Meaning what? Meaning you may look like demented. So vitamin deficiency may look like dementia. We call it reversible dementia due to certain B vitamin deficiency. So that's why before we diagnosed Alzheimer's disease or any other serious dementia disease, we need to do those blood work to rule out those medical simple things that you can treat so easily. Similarly, these are the serotonin rich diet. So when I was a resident, we used to tease each other that if somebody is depressed, give a banana. So one banana 3 times a day is a great treatment for depression. Everybody laughing, but actually not. Banana has the highest tyramine. Remember, tyramine goes into tryptophan. Tryptophan goes into serotonin and folic acid. So another thing is the turkey. You guys remember Thanksgiving Day? After the dinner, everybody is napping, yeah? Yeah, everybody is watching football game and half of the game people fall asleep. Why? Because we eat so much turkey. Turkey has tryptophan. Tryptophan goes after few things. Tryptophan is a good molecule like serotonin. It helps you to feel good. So everybody is feeling very happy on on with the serotonin, but serotonin ultimately converted to melatonin, which is our sleepy stage. So ultimate sequelae will be serotonin to melatonin, so people go fall in sleep. So see, these are all real chemicals in the brain. It's also available in natural food so much. So I could not, re-emphasize how much nutrition is so important for your good brain health. Okay, we have a 90%, about 90% serotonin actually not in the brain, in your gut. I call our GI doctor the psychiatrist of the gut, because these are the serotonin in the gut cause a lot of the symptom like irritable bowel syndrome, a lot of the colonic symptom, that psychosomatic disease in the colon, like IBS. Those are the things. Even with panic disorder, that's why when you get anxious, you have a butterfly stomach. So gut and the brain is so connected to each other. They have so much connection. So every depression patient have loss of appetite and weight loss. Every anxiety patient have a butterfly stomach, or feel like you have to go to the bathroom when you have an interview coming. Yeah, you have to go to the bathroom. You feel so anxious, so nervous. These are so connected. And then the last one is the GABA, gamma aminobutyric acid. This is a big one. GABA is the one that help you calm and help you relaxed. So when you have too much GABA, meaning it's a relaxation state, which is good for it. But if you have a low GABA, that can make you a lot of diseases. One of the biggest one is the epilepsy has the lowest GABA. So all the anti-epileptic drug we geared towards increasing GABA, which counterbalance the excitation called glutamate. So these are the two chemicals called glutamate, which excite the brain, and GABA, which relax the brain. So one make brain the hyper, one make brain the lower, relax the brain. You need to have a balance. So you need to have a glutamate and GABA in the same homeostasis. If you have a low GABA and high glutamate, there is sometimes we think cause of epilepsy, bipolar disorder, all kind of hyperactive state. Whereas, things that improve the GABA is the meditation, yoga, all kind of mindfulness techniques that relaxes you. And these are the medication, these are the food. Most GABA actually plant-based food. Highest GABA, I was surprised, is in the spinach. If you eat spinach with the egg omelette every day, you will have a relaxation. You will be so mindful with everything. So yeah, broccoli, mushroom, beans, grains, spinach, these are all good food that has a lot of GABA in it. So this is a old French word in 1826. I can't say the French, but you can, if somebody can read the French, I will say in English. What he said, tell me what you eat, I'll tell you who you are. So this is the French Revolution for food, how French become so good with their food selection, with their diet. So this is what I think we should focus, not only the portion control, also mindfulness of what you eat, what you put in your mouth. Okay, because whatever you put in your mouth has a consequences. So before you put in your mouth, think about what is the food and whether this food is causing anything opposite to what you're going through. Okay, so this is a very simple mindfulness techniques when you eat food. So neurocognitive health, the biggest revolution is the called mind diet. This is a diet. My patients probably get fed up because I tell them every time I see them about this mind diet. So they probably don't want to hear that. But mind diet is an abbreviation for MIND. Please Google it and print out all the mind diet recipe. Anyone who's attending today, and eat some of or cook something every day from mind diet recipe. It's so good for your heart, good for your brain, good for Alzheimer's disease prevention. So this mind diet is the Mediterranean and a diet called DASH diet. So it's a marriage between two different diet, Mediterranean diet and a DASH diet. DASH. DASH stands for dietary and sedentary, I think it's a blood pressure diet. So it's a low salt, low carbohydrate and low sugar diet. Whereas the Mediterranean diet, you already know, who has who doesn't know Mediterranean diet, yeah? But most Mediterranean diet has pasta and rice in it, yeah? So when you combine the DASH diet with the Mediterranean diet, you automatically lower the carbohydrate. So your pasta and rice gets lower. So you become a MIND diet. So MIND stands for, this is an abbreviation that you can see, Mediterranean Dash Integrated Neurodegeneration Delay Diet. It's a long word. What does it mean? Meaning, is it Mediterranean and Dash integrated, meaning they integrate, they are hybrid together. Neurodegeneration delay, meaning it can delay or slow down the brain's degeneration, brain atrophy, brain shrinkage. Can it be so powerful? What they did, and I'm going to share the research. It was in Scotland with 963 participants. They collected 65 and older people. They put them in two groups. These people doesn't have dementia. They're just 65 and older. They put them two groups. One group asked them to eat anything they like. One group, they only can eat MIND diet recipe. So they are very restricted with the MIND diet recipe. They had two MRI. One in the beginning of the study, it was a 3-year long study. So one was the beginning of 3-year study, 3-year study. One was post study, so at the end of 3 years. What they found out, amazing. People who followed the MIND diet, they slowed down their shrinkage in the brain, meaning their atrophy, their shrinkage that I show you in the MRI, in the hippocampal area, that can, so this is why Academy of Neurology really endorsed MIND diet. There was a big, I think you might have seen in 2006 when everything came. There was a big news on CNN and New York Times and everywhere. Diet that can slow down Alzheimer's. It was a big headline, and this was the MIND diet. So MIND diet study was replicated in Rush University in Chicago, and they found the similar Scottish result or the same. So it has been implemented in most neurocognitive specialists for Alzheimer's disease. And these are the history of the MIND diet. Dr. Martha Morris was an amazing nutritionist. She's the leader for the Rush team in Chicago for this MIND diet. And so this is the all the MIND diet recipes, basically leafy greens, berries, nuts, all the good fat that you see, like olive oils, those are all good, coconut oil, all the fatty fish. Salmon is the highest omega-3 that is in the MIND diet. All the other fish that you can eat, only thing you should not eat is the low density lipoprotein, which is the thing that causes heart disease and stroke, like LDLs, low density lipoprotein. What are the food in it? All the red meats, the beef and pork and all the butter, margarine, good stuff, but those are not good for your heart. And so if we can have the good fat, not the bad fat, and then low carbohydrate diet with tons of greens and vegetables, that's pretty much MIND diet. If you are a wine drinker, MIND diet does allow you to have 1 or 2 glasses of the red wine. It's funny because a lot of the time you have to be careful with the glass, because if you have a big glass, we're not talking about that kind of 2 glasses. We're talking about 5-ounce wine glass. So not too much. It's 1 to 2, no more than 2. But if nobody's drinking, then we should not encourage people to start drinking, although it is in the MIND diet. It's funny because when I was in Maryland at the Hopkins, one of the facility that I work was connected with an assisted living facility. So the patient with the daughter came, and I talked about MIND diet, and the patient learned. So that assisted living facility has a little bit of happy hour bar in the facility. So one day I'm finishing work and I'm walking by the bar. I see my patient sitting at the bar and he's like, "Dr. Upsar, I'm having my MIND diet." And he's having a wine, red wine. So next day he comes and his daughter said, well, he did have some MIND diet. He's like, "Yeah, I am having MIND diet." So I've said that other than red wine, are you still eating real MIND diet food, or is it just the wine? And then the daughter comes and she's like, "Can you ask him how big is the glass? You said 1 to 2 glass. He's like, yeah, I never drink more than 1 or 2 glass. He's actually drinking in a beer glass, like a big one. So we're not talking about that. So we have to be very careful about the alcohol intake. So we don't want, alcohol can actually have opposite effect of what are the studies, initial studies, what they showed moderate, mild to moderate drinking rather than large drinking. So we're not talking about that. So basically, these are the study results that I was talking about. They replicated in Rush Alzheimer's, Rush University Medical Center with the Dr. Morris, with the benefit in Alzheimer's disease. But diet alone is not enough. I think it was in the integrated first slide that I showed, that you have to have the other modality of the cognitive health, which comes the mindfulness, stress management, exercise. And exercise is three kind, yeah: physical exercise, mental exercise, and cognitive exercise. So we got to do all of them together, and that brings you the mindfulness techniques. So there are so many mindfulness nowadays we can do, including meditation. I don't have time to share with you but I have a lot of literature of FTG PET scan finding in Scandinavia as well as US and in Boston, where they have research showing mindfulness and yoga, how it can actually show changes in the brain in FTG PET scan. So it's more relaxing, increasing the GABA. Remember the gamma aminobutyric acid GABA slide, that relaxing chemicals in the brain. Every time you do a yoga class or meditation, you increase the GABA in the prefrontal cortex. That relax you, that makes you so calming, so relaxing. So that's why yoga and mindfulness is very, very important in anxiety disorder, panic disorder, any kind of hyperactive state. It helps in a cognitive state, decreasing agitation, especially in dementia patient. So I always recommend day programs or any kind of outpatient program have some chair yoga in their program implemented, so that this chair yoga, even though somebody has anyone can do yoga in the chair, even with the disability, and you can always modify that. So this is just what is about the yoga. It comes from this Indian Sanskrit language, meaning it's a union. It's a union between the mind, body, and soul. So in modern neurology, now we know this mind and brain, psychiatry, neurology, you can't just do that without the union between them. So that's why this mindfulness is so important in neurology and psychiatry. It's so much, in a mainstream medicine now. In a lot of the neurology literature, especially MS, that yoga and mindfulness has been so much commonly prescribed with patients with MS, epilepsy, Parkinson's, Huntington's patient, as well as, of course, psychiatric disorders. So these mindfulness and yoga help with not only dementia, really, it doesn't cure the disease, but these symptoms, which is easy to relax. Instead of taking the pill, you can also do something. I'm going to share with you one of the story. It's a real story. I was in Boston. This is the time in probably about 6-7 years ago. I was a medical director of a hospital in it's a Western Mass. One day I went there in the early morning. I see a nurse with a really stressful face. It's just 7 in the morning. She's already having a stressful face in her with anxiety, that giving me a look, and I'm like, what happened? Are you already stressed? It's only 7 in the morning. She's like, oh my God, this lady is driving me crazy. I have a lady here who just got admitted yesterday, and she's asking me 100 miles an hour, same question over and over, and I'm not sure how to do that. Can you please give me a prescription for Ativan? Ativan is a benzodiazepine. Remember the slide I show you, what other medicine is not good for you? So that's most commonly we use it for people when they get agitated or anxious. Yeah. So I didn't want to give Ativan to this lady because I know she already has memory problem. So I said, all right, let me see if I can do something about it. So I took hand with that lady, and we go for a walk, and I sat there and I said that, let's do some breathing exercise. And she's looking at me like, are you a real doctor or something? Why are you giving me a pill and giving me a breathing exercise? So few minutes later, after I trained her for the breathing exercise, I see her. She's not agitated at all. She was just sitting there doing her closed eyes breathing in and out with a 4-part breathing, they call it. So inhalation, hold, exhalation, hold, inhalation, hold, exhalation, hold. It's very good for anxiety manifestation, or they used to do it on the paper bag. Do you guys remember paper bag breathing in old days for anxiety? When you get anxious, they used to give a paper bag and say, breathe through the paper bag. But it's very true. It actually relaxes you because it decreases the carbon dioxide, CO2, which is the main. Carbon dioxide goes to your brain, makes lactic acid, which is the anxiogenic molecule. So you get more oxygenation, less carbon dioxide when you slow down your breath. So instead of breathing heavy, faster, you can slow down the breath. That will be one way to relaxes you. So this is very good techniques, because ultimately what happen is when you breathe this or meditate or do relaxation, this is the stress pathway. This is the hypothalamus, this is the pituitary gland, this is the adrenal gland. So the hypothalamus releases a hormone called corticotropin releasing hormone, CRH, goes into anterior pituitary gland. Then it develops this hormone called adrenocorticotropic hormone that goes into adrenal gland, where you get the adrenaline or stress hormone like cortisol. That cortisol increase your heart rate, increase your blood pressure, increase your sugar, and that they do it because that's the way of acute stress management. But if cortisol does not stop doing it, and then you become a chronic stress disorder, which is not good for you, because then you get a chronic blood sugar high, meaning diabetes, chronic high blood pressure, meaning hypertension, and chronic cardiac stimulation called the coronary artery disease. So this chronic stress can induce a lot of the vascular risk factor, heart disease and brain disease, as well as psychiatric condition. So this is why I always recommend mindfulness technique, whatever makes you relaxing. Stress management is a big one, because stress activates our sympathetic nervous system, and this breathing activate the parasympathetic nervous system. So it counterbalances the sympathetic by activating the parasympathetic to make you calm and neutralize the stress and anxiety. So it's a really, really scientific fact. So along with nutrition, has to be complemented together in order to slow down any progression of the disease, as well as prevention of Alzheimer's disease. And I'm going to finish my slide with this. This is a slide from my spiritual practice. Spirituality, Buddha said in the end, only 3 things matter. I shared this when I diagnosed patient with Alzheimer's after doing a PET scan, because most patient and family cries and they get decompensated by knowing they have a Alzheimer's diagnosis or this. And I shared this and I said, you know what? Buddha said, only you need 3 things in life. Only 3 things matter in life. The first one, how much you loved. Look how many people love you. You have a great family. They've blessed you. You're blessed by your family. Second is how gently you lived your life. Look how gently you lived your life. You worked hard all your life. You brought up your children so nicely. So you did everything for you. The number 3 is the hard one, and we're all suffering from it, is how gracefully you let go things that does not serve you anymore. So we need to let go. We need to let go things that we have no control over. We got to let go things that it doesn't make anything different, because we cannot let go to embrace new things. So we ended up going to a new relationship, but we have this baggage from the older relationship we don't let go. So you become tormented. Same thing happened with this diagnosis of Alzheimer's. People become so defensive that I don't have the disease. I can still drive. I can still doing this. I can still doing that. That's what I say, just let go. Except this PET scan is PET scan. You cannot say it's not there. It is what it is. It's there. But the idea is what can you do now that you know you have the disease to slow it down, to push it further away from you so that it does not affect you or interfere with your quality of life. So just remember the Buddha's three things in life: how much you loved, how gracefully you lived your life, and how gently you lived your life, and how gracefully you let go things that does not serve you anymore. And with that, I will stop and I will see if you have any question for me.
There are two questions in the chat already, Dr. Absar.
Sure. Okay.
But why don't I read the first one? Dr. Berg, the nutritionist, discusses the importance of intermittent fasting to prevent the tau and amyloid from getting more prevalent. What is your opinion of fasting?
All right. So now I have to be honest. I can respond to that my personal answer, not professional answer. So don't quote me for that. That's my personal as a nutritional, and remember I have a lot of other hat I wear, not as a neurologist or a neuropsychiatrist. So I'm going to give you my personal. I personally like intermittent fasting. I personally feel that disciplined your body, and there are a lot of scientific literature. It's pretty early, but so far, especially with the New England Journal study, does show how it can actually help with not the longevity, but also with the cardiovascular health. So I do have. I think what um, we need a long-term study for that. So it's too premature to give a conclusion. But you have to be careful when you choose the intermittent fasting. Whatever works for you is good, but starving when you are hungry is not good idea. So you have to discipline. You have to go and tolerate your body for that. So I don't like that when you force your body to certain way, because that's really not good for you you know
Mm.
but in the contrary, I also like the idea of everything in moderation. So I think portion control and having a low carbohydrate and low fat, and then having a good fat though, with the good fat, olive oils and avocado and all the other berries and all the other stuff, those are fat, but those are good fat, and pretty high protein, more like a mind diet that has more literatures out there. So that still, I think I recommend.
Okay. Um, there's another question. She says, so Aricept is no good for dementia and cognitive skills. I don't believe that's what you said.
No,
No,
I couldn't understand why you said that. I thought my slide has a opposite. Remember
it's
the
the
medication
opposite.
that we talked about? Make sure you don't forget about that. All right, I'm gonna bring that
This
slide
is
back.
very important, everyone.
Make sure that where the slide goes, that integrated health strategy. So what are the integrated health? Remember that slide? So the number one is the cognitive enhancement therapy. Aricept is this, donepezil. See that?
It
So
is
make sure
very
medication
helpful.
is number one. You have to have it. You can't have all of them without the medication, memantine and donepezil. Aricept is the generic form is called donepezil, and Namenda generic form is called memantine. So these are the same thing. Okay? So please don't misunderstand anything.
That was very important. Thank you, Dr. Epstein. Okay. And there's another question. Can bipolar mood disorder, anxiety, depression, stress, suicidal have an effect in a 24-year-old young woman for dementia? Uh,
Do
recommendations.
do you
This
have the
is,
person they can speak up
yeah.
so that they can explain?
Yes, would you
Whoever
try to
answered the.
unmute yourself if you're on?
Hi,
Hello.
hi.
Uh,
I have. there was a twofold also with that question. I apologize. I misunderstood with the Aricept. Sorry about that.
Oh, no, no problem.
I appreciate you clarifying that. Um, so is it also hereditary, the dementia part, Alzheimer's dementia, and is for on a 24-year-old young woman who's been stressed, suicidal, depression, and all those other things that I wrote in there. Is that something that could also turn into cognitive skills um, decline and into dementia?
That's a great question. So uh, let's try the first part, the genetics part. The genetic part is a $1 million question. We're still struggling with a lot of different data. But so far, what we know, all Alzheimer's disease doesn't look like purely genetic. So there is a gene called APP, which is a familiar, it's a gene of multifactorial gene, meaning if you have that gene and if you get that APP gene or lipoprotein gene, then this kind of multifactorial transmission, you have the gene but you also have the control, meaning if you're sedentary, you have diabetes, if you have high blood pressure, you have all of the other, like a stroke risk factor. So if I have a family history of stroke and I don't exercise, I don't eat good, I don't eat right, then of course I'm a high risk for stroke. But I do have, not necessarily I will automatically get a stroke. So that part is majority of the late onset Alzheimer's disease, meaning Alzheimer's disease that starts in your 60s, 70s, and 80s, most likely a multifactorial disease. So that has a vascular component, that has an aging component, that has an environmental component, and they have a genetic component or family history. Whereas there are very limited early onset Alzheimer's disease patient who has two different transmission. One, we see that with Down syndrome patient called autosomal dominant transmission, meaning autosomal dominant Alzheimer's disease, where Down syndrome, all the Down babies used to die before because of the cardiac anomalies. Now that our cardiac surgeons are so good, they actually can fix a lot of the stuff. So the Down babies can live longer, and sometimes this transmission from the Down to Alzheimer's took place because this Down also have something similar to amyloid pathology in their brain. So it's a similar disease, so it transforms into that. That's a pure genetic, it's an autosomal dominant transmission. There is also early onset, there are some familiar Alzheimer's disease that we know, but those are not the majority of Alzheimer's that we see. So I don't want everyone to get panicked that we have Alzheimer's, maybe my daughter will have Alzheimer's, most of them are Alzheimer's. If you have any doubt, you can go for genetic testing, but to be honest, we do not recommend that because number one, even as you saw, even if you have amyloid in your brain, we thought that in ideas, the study that I was in Maryland, a lot of people, they have positive amyloid scan, but they did not have the disease. Okay, so there are incidents where you have the brain pathology, but it did not evolve into the disease. So, and also as you get older, like if you're 100-year-old, you will have amyloid in your brain because that's the aging process. Not necessarily it will evolve into full-blown dementia. So I know there is a lot of fear out there about the genetics, but I have to be very cautious. We could recommend very cautiously that majority of this disease that you see are multifactorial gene. So gene is there, but your control is there. So if you can do the cognitive health, this is the whole lecture about cognitive health, nutrition, physical exercise, mental exercise, stress management, mood, anxiety management, remember sleep management, you have to sleep better, and all those avoiding certain medication like anti-Aricept. I think you misunderstood about that. Anti-Aricept medication like the Benadryl type of over-the-counter cold medicine or sleep medicine that they prescribe, those are opposite to Aricept. So those will cause dementia-like symptoms. So if you can avoid having great relaxing life with a good stress management policy, healthy lifestyle, with good mind diet, physical, mental, and cognitive exercise, I think you will be good. You will be you can, even though you have the risk, you can slow it down or push it further away from you. In terms of the second part that you talked about, the bipolar disorder or mood disorder, we really don't have enough literature for me to comment on that. But psychiatric condition like mood disorder can mimic dementia-like syndrome in the elderly, in the older age. In 34-year-old, I would not feel that would be the case because you have such a cognitive high cognitive reserve, so you can compensate that, but having said that, 34-year-old even with a bipolar or severe depression can have apathy and attention problem or focusing problem. If you have a focusing problem, you're not gonna remember better because you never paid attention when you were learning. So you may complain you have a memory problem, but that's not memory. That's more trouble with your focusing. So you got to be careful. So that's what they used to call pseudo dementia in depression. We don't call it pseudo because it's real dementia-like symptom when you are depressed, but it is treatable because if you are treated for depression, it should go away. It should be better. It should improve.
Thank you, Doctor. So, any other questions? Please just unmute.
This is Joe Wolf. I have a question.
Hello.
Hi, thank you very much for the lecture. It was very
Thank you.
it was very interesting and stimulating. And thank you, Pam, for arranging all this. My wife has Alzheimer's, and I had two questions. One was about the medication. She takes the donepezil. She's actually started taking that when they only suspected she had Alzheimer's and didn't confirm it. After she had a stroke, she had symptoms that waxed and waned, and then a couple of years later, they suspected it was an underlying condition, and since then she has full-blown Alzheimer's, and she's very inert. She doesn't, she doesn't really want to get out of bed. That's one of the biggest symptoms, and there's been various ways that they've attempted to, to get her to, be more motivated to get up. Again, if she sees her grandchildren or children or the volunteer that comes, she gets up and participates. But if she doesn't have anything specifically like that, she prefers to stay in bed and have her meals in bed and just stay in bed. But in any event, because of that, the psychiatrist, and I think she was on Zoloft, and that she got brain fog, and then she went to desvenlafaxine, which is Prestige, and she's been on that for several years, and that, definitely helped her mood. She, didn't have the same kinds of mood swings, and that seemed to have been a very positive thing. And now, after a lot of time and the whole idea of like getting her up, the psychiatrist wanted to subscribe, in addition to the Prestige, a medicine called Abilify, aripiprazole, or I don't know how to say these things. Are you familiar with
Yes.
that?
Yes.
And I haven't. The neurologist said that it, was used in conjunction, and she wasn't concerned, and her cardiologist and her regular doctor weren't aware of it, didn't know about the drug.
Mm-hmm.
And it scared me to death when I read the thing from Walgreens, which is, this drug is not for older patients with dementia. That's the first
Right.
line in the warning. And they talk about, if you have all of these various things, that my problem would be, these are the symptoms that she has. And it's like, so unless they were really dramatically more, I wouldn't know. So I was curious, do you have an opinion about Abilify?
I'm so glad you asked this question because this
Grateful.
is really a great question. Remember a molecule I talked about, dopamine? Do you guys remember the dopamine?
Yes.
So
Right.
we have this prefrontal cortex that is a seat of dopamine. So remember how dopamine activate your happiness, your motivation? This is the motivational areas of the brain. When the disease, whether it's an Alzheimer's disease or a stroke dementia or Parkinson's dementia, whatever it is, whenever the disease comes to the prefrontal cortex, that dopamine area, you lose the dopamine. So apathy is what you see in your wife. That's not so much depression, that's like a lack of motivation. When she's motivated, she will get up. So dopamine is the happy molecule, yeah? What's the artificial dopamine she's getting? Your grandchildren.
Mm.
When the grandchildren comes, your brain see
Right.
the dopamine. So up because so you got to create a structured activity that's passionate to her, because I have the similar situation with a lot of people. They love music, and if you bring the music or something that they really love, so they may be getting out of bed more, really. So if she's home, if you have a home health aide or someone, create a program for her. Then I'm going to comment about the medication. So make some structured daily routine for her so that she doesn't stay in bed, because your frontal lobe does the routine for you. When you don't have the frontal lobe, you have nobody to make a routine for you. So it doesn't matter what time you wake up. It doesn't matter if you stay in bed all day long. So you have to be the artificial frontal lobe. You have to create a discipline for her. She was gonna hate it first few days, but you got to stay with it. But her brain will get adapted with that change. So wake up at certain hour, get breakfast at certain hour, get a book or even picture book just to see some picture, or maybe piano, somebody have a music or have a music played to her own song, like things that she used to love before, old music or old something. Create a program that is good for her, or maybe Zoom call with your grandchildren, or something that makes her happy. Do so. Those are essential before I comment on the medication. So without that, medication alone is not good, because this is not a psychiatric condition what she's going through. It's an Alzheimer's disease. It's a neurological disease with frontal lobe symptom, which looks like psychiatric symptom, but it's not psychiatric. So when you treat this symptom with psychotropic medication, it only slow down the symptom. It's not going to cure that. Okay, if it's gonna come back. So you got to be have a realistic expectation, and that's why you do need to be educated constantly. Even educate your psychiatrist if they are not familiar with Alzheimer's disease that much, that we understand that this is a prefrontal cortex, this is the dopamine problem. So I give a plus to the psychiatrist. They did a good medication choice, Pristique, venlafaxine, which is the choice that I would have done, because that is a different chemical than the SSRI that she was on. Because remember, it's a dopamine problem. So the Effexor and Pristique has a little bit of noradrenergic and definitely some dopaminergic effect. So it has a lot of effect on motivation. So it does. Bupropion is another one which does very much. Wellbutrin, which is another antidepressant, which is very good for dopamine, which also help with the dopamine choice. But so those are the medication. In terms of augmentation, meaning adding another one, is very common practice. It's not uncommon to add another medication. Abilify in its very small dose. Abilify is called aripiprazole. Aripiprazole is a partial dopamine agonist, meaning pharmacologically, in a slow dose, in a small dose, it works as an agonist, meaning it can increase the dopamine. In a high dose, it works as an antagonist, meaning decreasing the dopamine. So remember, what is improving the dopamine means? Improving dopamine means happiness, less depression, and improving Parkinson's, like movement. So all the sorry? Oh, all the Parkinson's medication and all those are the dopamine agonist, yeah. So Abilify in a small dose, they found if really good for adjunct for mood features like depression. But remember, Abilify is an antipsychotic medication. It's not marketed for small dose. It marketed for the higher dose, which is used in schizophrenia and bipolar disorder for hallucinations, delusion. So we don't want that kind of dose. We want very small dose, less than 2 milligrams sometimes, or maybe no more than 2.5 milligram a day, because you just need the boost to boost up the mood. So that is doable. In terms of the what you found out on Google, these are the FDA black box warning. So FDA, what FDA say, they have a lot of studies. It's not just Abilify. All the medications, they call it new atypical antipsychotic medications like olanzapine, clozapine, Abilify, risperidone, geodon. These are all class of drug called antipsychotic medication. When they used in certain dementia patient, again they didn't do the study really good because they didn't have a way to uh, change a lot of the other comorbidity like vascular disease, other comorbidities that those patient has, heart disease, pre-existing cardiac morbidity or stroke or aging. They found out they died a little bit earlier from vascular disease, and sudden death was few of them. Sudden death happened, and most of that death was from sudden disease. So they interpreted, they didn't know what to make it. They interpreted there might be a relationship between this medication and sudden death. Because dementia research, you can't do it for a long-term study. You need a long-term study to prove that, because people die before you complete the study. So we don't have enough data about those medication for long-term. So FDA, being very political, what they decided to do, they are not going to comment is good or bad. They're just going to put up some sign what they found out for that short-term study, that they put that as a black box warning. But they say that it is between you and your doctor. If you both decide, that's between you, don't sue me. They're basically just clearing themselves. Federal government was just saying that it is between the doctor and patient to decide about those. But in terms of the research, they don't have enough data long term to see the efficacy, but the short term research did show some of those. As I said, we don't know those people died because of their comorbidity, because most people in that age has cardiac disease, has heart disease, has lung disease, have a lot of other disease. We don't know if it's the chicken or the egg, what was the case of. So there is a lot of cofactors involved that was not clearly cohorted or clearly clarified in this study. So I understand it's very uncomfortable, but I think the psychiatrist, we could talk to the psychiatrist, but they did the right thing about the medication choice in a small dose, though, not higher dose. But if you are uncomfortable with that, which I wouldn't blame you if you are uncomfortable, but to be honest, you will see almost majority of all dementia of any kind, including Alzheimer's disease, is on one of those medicine for sundowning behavior at night, because we have nothing to offer for this dementia patient. So without those medications, it's impossible for caregiver to care for them. And there is not enough literature for those positive effect. I mean, I wish they had more Google search with this positive effect of those medicine in dementia care, because how they are helping this behavior, keeping patient in their own home longer so they don't have to go to nursing home, because caregiver can manage their behavior because of those medication in there. But about that FDA warning, it is there, it is out there, and it is a fact. But as I said, it has a lot of unclarity, that those comorbidity wasn't clear cut about those sudden death because of the vascular death, whether it was from the medication or is it from the chicken already there. Chicken came first. So that's kind of
Yes.
long answer. I hope that
Uh,
explained.
So it was extremely helpful. So 4 milligrams would be much too much.
I think I wouldn't go for. I would go 2 milligram.
Mm.
The, because the efficacy, unless they're using it for behavior, if they're using for mood, like motivation, then you need the lowest dose possible. And there are a
Okay.
lot of other medicine that they can also try, like a small dose of Parkinson's medication. Miraplex, one of the medicine we prescribe for Parkinson's disease, is also used it for motivation, apathy. Amantadine, which is a Parkinson's medication, is use it for apathy, motivation. So you can also talk to your neurologist about that because those medication are also a safer choice, and that can also help with the motivation too. But psychiatrists did choose the right medicine, but maybe a smaller dose would be preferable.
So that, if I have time for one more quick question, a different question.
Yeah, we're
You-
running close to time, but yes, please go ahead.
Uh, in terms of focus, my wife before her stroke, which was 5.5 years ago, was Miss Multi-Purpose. I mean, she did dual focus, interrupted. If she definitely, focus was not a problem. And immediately after the stroke, she, was incapable of doing things that required, sustained focus in terms of
Joe,
being able to keep focus. So the focus problem happened immediately. And
This is why.
that
Oh, sorry. Go ahead.
so my question is now in terms of her focus, which like to get her to like walk, she suddenly sees every speck of dust and stops and then cannot sustain focus on anything she's doing that she doesn't want to do. Is that the Alzheimer's that has kicked in?
So I am suspecting, again, without knowing anything about your wife, I am suspecting she has a mixed dementia, partly Alzheimer's and partly vascular disease from the stroke. I'm suspecting. Alzheimer's disease starts in the hippocampus, and the time that it comes to the frontal lobe, usually end stage. So you don't see Alzheimer's patient with this kind of symptom that you are seeing in earlier disease. So these are the symptom. Attention, focusing, motivation is the same. Dopamine is the same frontal lobe I'm talking about. So you're talking a lot about frontal lobe symptom that make me wonder whether she had a stroke in this frontal lobe pathway. That is why she's so depleted with dopamine that her focusing is off. She cannot do multitasking anymore. She cannot do sustained attention anymore. And she has no motivation and apathy, lack of interest to do
It was a
things.
thalamus in their thalamus. It was a
So that's
thalamic
exactly.
stroke.
So the thalamus is the, I'm so glad. I wish I had time, maybe next time. So there is a pathway called frontostriatopallidothalamic pathway, meaning it goes from frontal lobe to the basal ganglia to the thalamus and can come back to the frontal lobe. This is a loop, closed loop pathway. If you have a stroke in any of these area, whether in the frontal lobe or the basal ganglia or the thalamus, your frontal lobe will not work, your basal ganglia will not work, and your thalamus will not work. What frontal lobe does? Executive function like divided attention, sustained attention, multitasking, problem solving, decision making, motivation, depression. What basal ganglia does? Movement like gait, walking, tremor. What thalamus does? Memory. So these are the things when happen, I call it a syndrome of 3M. Mood and motivation, followed by movement and gait problem, followed by memory and executive dysfunction. These 3M collectively is the sign of vascular dementia. So I see her, she has both. I see her, unless she has an advanced Alzheimer's disease, where, as I said, Alzheimer's in the last stage, it comes to the frontal lobe. But if you have a stroke starts here, this thalamic stroke goes here, and her memory is here. So she has both dimension symptom. So this is something I think you should entertain with your neurologist, just an academic exercise. Just say that I had a lecture about this, and I was wondering, she has a lot of frontal lobe issue with motivation, with mood, with apathy, with attention, sustained attention. And also she has this traditional memory and Alzheimer's type symptom. Do you think she has a mixed dementia or she has an advanced Alzheimer's, so it involves the frontal lobe? See what they say. But to be honest with you, if she doesn't have any anxiety or never had a seizure disorder, bupropion would be a really good choice for her, knowing she has so much trouble with attention span. Wellbutrin, which is great for motivation because it has a load of dopamine it can release. So that would be another thing that you can talk to your psychiatrist and neurologist. Okay,
What
hopefully
was
that
the,
would be helpful.
thank you. So, what's it called again?
Wellbutrin.
Wellbutrin.
Wellbutrin, which
Yeah.
is a Parkinson's medication.
No, this is a
Oh.
depression medicine. This is a
Okay.
depression medication.
That would be instead of the Prestige.
Probably, yeah. I wouldn't do
Okay.
both. Probably one or
Thank
the
you
other.
so very much for all
You're
of this.
welcome.
Really,
Thank you so much, everybody.
Oh
Thank
my
you so much.
God. Thank you so
Thank
much,
you. I
Dr.
really appreciate.
Aptar.
Thank you.
This was wonderful. Thank you very,
Thank you.
very much.
Thank you, Pam, for
Oh.
coordinating everything. Bye bye for now.
Okay. Bye-bye, everyone.
Bye bye.
Bye bye, Pam, and thank you very much.
You're
Bye-bye.
most welcome. See you all soon. Bye-bye.